And joining us now on the debate in Washington, D.C., Daniel Greenberg, author of Science for Sale, The Perils, Rewards, and Delusions of Campus Capitalism. And here in studio, Dr. Miriam Schuckman, research ethicist with Women's College and Sunnybrook Hospitals here in Toronto. Dr. Matthew Stanbrook, deputy editor of the Canadian Medical Association Journal. And we welcome back Seth Mnookin, author of The Panic Virus, A True Story of Medicine, Science, and Fear. Welcome to you two here in the studio. Daniel Greenberg, good to have you on the line from D.C. Let's pick up from where our last interview with Seth left off and get into some more detail about what Andrew Wakefield actually did wrong, because we didn't spend much time on the nature of his fraudulent science. So resist the temptation to tell me every single thing you know about this in the first answer, everybody. Just let's make a list here. Miriam, start us off. Name one thing he did wrong, Wakefield, in his conclusions.
One of the things he did is that he misrepresented what he'd actually done. So he listed out children, it's a study of 12 children, and he listed them as having had certain symptoms that came 2 weeks after they got this vaccine. And when people went back through, especially an investigative journalist who went back through all of this, what they found was that's not what happened. If you actually talk to the parents, the stories were different for every one of these children, and they weren't the symptoms within 2 weeks of the vaccine.
So misrepresenting the facts is pretty bad. Daniel Greenberg, what else did he do wrong?
Well, I think he took a very, very thin amount of evidence and he formulated it in a way that was bound to create enormous public concern. I think this fed into the press very easily, and the result was this catastrophe that we're still living with.
Matthew Stanbrook, what would you add?
He misrepresented the scientific design of his study. This was a case series, which is a low level of scientific evidence to begin with, but often important in identifying sentinel events. But he said that these were children who would just happen to come, one after the other, to his clinic in the routine course of seeking medical care. And that, in fact, was a barefaced lie. They had been deliberately arranged to come, recruited from all over, including from the Western United States, by a vaccine advocacy group for the express purpose of showing the results that he was going to find in the study before he'd even begun.
Seth, do you want to add the financial conflict of interest to the list?
Well, the other thing, or one of the other things that came out, I think it took 6 years before this came out, was he had actually taken out a patent for a potential alternative measles vaccine about a month before this paper was published. And obviously, if parents were not giving their child the 3-in-1 MMR vaccine, they would be looking for another type of vaccine.
Got into a financial conflict of interest too, though, right? He had people paying him to essentially come up with certain facts that were in their interest. You want
Absolutely.
to talk about that?
So
well, it wasn't. Yeah, no, I'm sorry. I mean, I think what you're referring to is the solicitor in the UK who was working with some of these parents.
Yes.
that had been funneled to Wakefield. Through Andrew Wakefield's work with that lawyer, his lab had also received some funding to conduct research. So it wasn't as straightforward as he was being paid to give results, but he was receiving funding related to potential lawsuits about this issue.
Would you add anything to that, Miriam?
Well, I think what Seth was starting to say before was he had a business interest that would, if everything went as planned, so if people believed his research and believed that the vaccine was responsible for the MMR, he had a new vaccine that would go on the market, and then he would earn money from that, so that there were sort of these
perverse incentives.
Yeah, absolutely.
Okay. Matthew,
But
let's try.
I think it's too much to...
Go ahead, Daniel.
I think it's too much to ask the public to be on guard for this kind of pathological behavior in the scientific community. It's the institutions of science that have fallen down. I mean, where he was working, observance by his colleagues, the peer review at the Lancet and others, I think that's where we see the failure of the system. That the public became alarmed, well, I think was almost certainly predictable, but that the public should understand the intricacies of bringing science to publication, I think is asking for entirely too much.
No, fair enough. But Daniel, why do you think these institutions of science, as you've called them, fell down so badly?
Well, in general, I think that university science departments and hospitals, don't like to play the cop watching their staff members. And if a professor in these hard times brings in, a couple of $1 million from the pharmaceutical industry, the dean of his school is not going to frown on this. People are told to go out and forage these days. The pharmaceutical industry turns out to be perhaps the best alternative to government money. But government money is very, very tight. So we see, very undesirable relationships developing between researchers and commercial organizations. Sometimes the researchers are freelancing on their own, as Wakefield was to some extent. Other times they're in cahoots with the pharmaceutical industry. But I think we can't expect the public to understand all this. The scientific community, first of all, has to be much more observant of what's going on within its own ranks. And the science and medical press, I think, have to be very sensitive to the realities of what's going on in the scientific institutions.
Matthew, follow up if you will.
I think you can certainly fault the institutions of science in some ways for things that happened around this scandal. But at the end of the day, this was not primarily the fault of the institutions of science. It was the fault of one researcher who lied through his teeth. Wakefield. And the fact of the matter about science is that at the end of the day, it is based on an honor system and on trust. At the end of the day, we scrutinize, we question, we never cease doing that, but at the end of the day, we trust that people actually did what they say they did. And if an intelligent and unscrupulous person constructs plausible lies, it's really very hard, initially at least, to catch that, even for very smart journals and institutions to catch that, although certainly there were many things that could have been done better in this case by those institutions.
I thought, though, Seth, part of the idea around all this is to get peer review. And, nothing gets published until it's really past the sniff test, if you like. Where did all that go?
Well, I think that in some ways there are two different issues here. There's sort of the case study, if you will, of the Wakefield paper. And then there are larger concerns about the scientific paper and the academic paper process. In the Wakefield paper, peer reviewers did actually raise concerns. And in fact, there was a commentary for that reason, in part, a commentary commission that ran in the Lancet that was very critical of the paper, which is unusual, very, very unusual to have that happen. So I think the Lancet tried to telegraph that concerns had been raised. In this regard, I think I agree with what Matthew had been saying earlier, that there are situations in which a case series is an important starting point. And we also clearly assume that people are telling the truth. In this instance, as I said before, I really think that the institution that failed at the outset was the media, was the science and medical press, who should have reported that you don't draw these type of conclusions from a case series, that all of these other questions had been raised in the peer review process and had been raised publicly. I think that specific case is a little bit different from the points that everyone has been raising, which is there's a lot of concern about transparency. There's clearly a lot of concern, and in many cases for good reason, about pharmaceutical companies' ties to researchers, about researchers who have their names on papers who actually didn't work on them.
Well, let me follow up with Miriam on that.
But I think in some ways,
Miriam wrote a book about this, and a book that got a big prize, if I remember well, the Shaughnessy Cohen Prize. What happens when, research studies and pharmaceutical companies that aren't necessarily all on the up and up and particularly ethical, what are the pitfalls of that relationship?
I think it's partly what we're hearing about here. I mean, the pitfalls of the relationship are, the companies have a very clear motive. They need to do well by their shareholders. They're funding the research. And what you need is a clear division between the people sponsoring the research and the people doing the research. And what the journals have done, to their credit, things have changed even since 1998, since Wakefield's paper appeared, and the journals have made it increasingly clear that they won't publish research when there's not a clear firewall between the company or whoever is sponsoring it and the people doing the research. And I think that does help. That helps the media, it helps the public, because as has been pointed out in our discussion, it's not for the public to figure out where are all these conflicts, but it is for the journals to set these rules, and they have increasingly set more rules around that.
I want Daniel Greenberg just to take a moment here and help us with some of the history here, because I guess some of the parents who would be in their 40s and 50s and who are of the belief, mistaken though it may be, that this MMR vaccine somehow caused the autism in their kids, they remember back when Gerald Ford was president, and they remember a national effort to vaccine kids against swine flu, and they remember that it didn't go very well. You want to help us with the history there, Daniel?
Well, I don't know if we can specifically link the swine flu episode to what happened a considerable number of years later.
Well, it certainly created doubt in a certain generation of people about the efficacy of these programs, didn't it?
Well, there always is a substantial part of the population that believes there wasn't a moon landing, that UFOs do exist, that vaccines are dangerous. I think it is the responsibility of the science press and the scientific and medical communities to try to keep the record straight on these matters. But you're always going to have some people who are going to say when misfortune occurs, we can spot the origins of it. I think the real failing here was that on the basis of 12 cases, a really explosive paper was published. And the consequences of that were, I think, were probably quite predictable, because the Lancet was quite nervous about publishing this. And there is a hot competition that goes on among the 3 or 4 leading medical journals for the big papers. I don't know whether that was applicable in this particular case, but they're always on the lookout for it. Now, as was previously noted, the journals have cleaned up their act to some extent, but there still is the pursuit of the big paper, of the front page New York Times report saying yesterday in the journal of such and such it was reported. And I think this was foreseeable. This paper never should have gone into print on the basis of 12 cases.
Okay.
And I would just add to that, Daniel, I agree with you, and I think it's one thing for the paper, we can say it's science, it deserves to be published. It's very different to say it deserves to be published in the Lancet, right? The news attention that goes to the big 4 or 5 journals, right, is so different than the news attention that would be paid to a very small, limited readership journal. And I think you could have argued that at the point at which the Lancet was soliciting an editorial that was so critical, they might have said, you know what, let's leave this for another journal to publish. It's not for us. It's not yet ready for prime time.
Matthew?
And this is where I think you really, I'd really pick up on Daniel's comment about the consequences were foreseeable. If you can fault Lancet for anything in their decision, you can fault them for not having foreseen, as they should have, the impact this would have on the public given the nature of the anti-vaccine movement. They should have foreseen that, and that was a big mistake.
Okay, let me broaden our discussion here, if I can, to beyond the Wakefield and autism issue, because there's another example that's been in the news a great deal over the past year, and I'll bring up this graphic here from our national newspaper, the Globe and Mail. This was in just a couple of days ago. We're calling it to Zamboni or not to Zamboni, and it's got nothing to do with cleaning the ice at the end of the period in a hockey game. Ever since it was introduced about a year ago, liberation therapy has divided doctors and their patients. The treatment is highly contentious because it disputes the long-held view that MS is an autoimmune disease. Dr. Zamboni believes MS patients have damage in blood vessels in their necks caused by too much iron. He has developed a procedure to clear the blockage, which involves opening veins in the neck and spinal cord. He believes this procedure combats symptoms of MS, which can cause loss of balance, impaired speech, extreme fatigue, and paralysis. Okay, here's the conundrum, and Daniel, perhaps you'll start with this. Patients, and we've interviewed them on this program, say liberation therapy works. It alleviates their symptoms. It makes them feel better. They want to get government funding to improve research and improve the treatment. But the Zamboni hypothesis is still technically unproven. So what do we do?
Well, you've got cancer cures available all over the world that are not certified. And you got people streaming to them in desperation. And you get a testimonial saying this really works. We have gone way beyond that system of patient testimonials. And we do have procedures, they may not be the most perfect, for getting a fairly sound scientific understanding of whether something is beneficial or not. Now, the procedures that you describe undoubtedly are satisfying for those patients who say they've been relieved, but that you can't inflict the whole system, the whole therapy on the rest of the world on the basis of their evidence. That's where I think the medical and scientific communities really have to get much sharper and much more dedicated, and again, in collaboration with the scientific and medical press, try to educate the public. The problem will always be there. It will never be completely solved, but it certainly can be alleviated.
Seth, where are you coming from on this?
Well, you know, I think a really an interesting situation here is in that patient population, what you're primarily dealing with is patients who feel like there aren't other options. They're not being presented with another possibility by the medical community, by the mainstream medical community, or another option that has been tested. So it's very hard to tell those people, you shouldn't do this. But there's nothing you should do, and that has come up again and again in the autism debate, because tied in with the whole vaccine issue is the notion that if vaccines are to blame, here are these whole series of cures that can cure your child of autism. So you know, I'm not so sure that this is a kind of institutional medical issue, because I think as long as and whenever there are people who feel hopeless to some extent, it creates a vacuum where you're going to have people trying to fill that need. The issue here is when you have people asking for cures that haven't been proven, you know, one, they might actually be dangerous, and two, it makes it increasingly hard to actually put those potential cures to the kind of rigorous scientific testing that could show, yes, they really are beneficial, or no, they're not.
Miriam, help us with the ethical side of this. What do you do when something works, but technically it's not considered approved?
With the Zamboni thing, it's very complicated, right? Because it's not even clear quite how we would test it, right? You know, CIHR considered this and said it's not
Canadian Institute
of Health Research. They looked at this and said, can we do a clinical trial? Can we test in Canada whether or not this therapy works? Other places have looked at it and said, yes, we can. Let's go ahead and do this. And they looked at it and said, no, we're not there yet. We don't have the science. But that really is the issue. Patients want to know, does this work or not? I want to try it. I've heard it works. I'm going to go somewhere where I can get it.
Well, then the government of Saskatchewan goes and gives them, what, like $1 million of research money or something?
Yeah, they say, look, it's worth finding out. Yeah. You can see that argument. And the argument would be, just what we're hearing. Parents are going to go looking for something for autism. These people are going to go looking for something for MS. The things we have available aren't very good, the drugs we have available. So they are going to go looking for it. So you can argue, let's come up with whatever test we can of this therapy they want so that we can try and get some data here.
So Matthew, how long would it normally take to go through the entire process of doing testing, the results of which were so conclusive that all governments would jump on board, the scientific, the research community would jump on board, and we could say, yes, this works, let's go do this?
To get that level of certainty sometimes never happens, but when it does, certainly takes many years. And one of the things about medical research is there's this balance between wanting to get new therapies available to help people who very badly need them, and wanting to be sure that things work and are safe. That tension is with just about every therapy we have in medicine. But the Zamboni example is particularly acute because here you have a situation where people are desperate, and you both have to acknowledge their right to want to pursue things, even if they're potentially dangerous, but also acknowledge the potential for that to be exploited. And I think if you want to narrow it down to what's wrong with the Zamboni procedure as it's being operationalized in the world, it's not the patients who are wrong for seeking it. It's not the researchers who are wrong for putting forward an unconventional hypothesis about this, or a journal for publishing that if it's been properly written up. It's the people who are offering this therapy without the oversight that should be there in an investigational procedure, without the research ethics approval, the safeguards that goes into research. where they are profiting from this, whether they're doing it nobly or otherwise, doing it without the safeguards. That is the problem with this. It should not be available outside of a research context.
Daniel, do you want to follow up on that?
Well, we long ago decided that the public is gullible, and there are snake oil salesmen out there who are very eager to exploit them. And that's why we instituted a whole series of processes and safeguards. Now, when we bump up against a situation like Zamboni, we have to go back and say we do have methods for testing these things, for making sure, and for avoiding the exploitation of desperate people. It's the extreme cases like this that really test the system. And I think that's when we have to be loyal to the system, to improve it as best as we can, but not to throw up our hands and say, well, nothing helps these people, so let the snake oil guys, exploit them and get rich off them.
Seth, help us with this one here, because coincidentally, and I'm trying to remember where, I think it was a lung cancer study that was done by a professor at Duke University, and I think he just resigned because he took a second look at it and realized he had to pull the study. What he found the first time he couldn't replicate, and therefore the study has been, quote unquote, retracted. How often does something like that happen?
I actually don't know about that specific case, but I mean, one thing I would say is I think a researcher should be given tenure if he goes back and says publicly, you know what, I had these conclusions and I've done more studies and I was wrong. I think one problem is that there's this sort of institutional notion that, and you see it in the media also, certainly, that by acknowledging places in which you might be incorrect, you're somehow telling people that you're particularly vulnerable to attack. Science proceeds by results being improved on and sometimes being overthrown. One thing I just want to add to what Matthew said, and I cannot agree with his last point more. I think I really agree with every part of that. And I think the reason why it's so troubling that you have people willing to take advantage of the situation and offer these cures, potential cures, outside of a research environment is because of exactly what we've been saying, in that then you have people saying, this worked for me. And we know again and again and again in these situations that people's sense of what happened to them in a circumstance like this oftentimes just does not match up with the reality, either because of the placebo effect or because they so want something to work that they report the results are different from they are. But that's why it's so crucial that when you do have explorative therapies, when you do have experimental therapies, that they get conducted and tested in a way where we can rely on the results. Because you end up having this sort of avalanche phenomena where more and more people say, yes, I got this unsanctioned therapy and it worked for me. Then more people want it, and then you have even more people saying it.
Matthew, you had a quick follow?
Yeah, the nature of retraction of publication bears a bit of a comment. It really depends very much on the context of that. Wakefield's retraction is very different from that of a researcher who on their own say, we followed up on this and we were wrong, and we want to tell the scientific community we were wrong and withdraw what we said. That is a normal and very important part of science. It happens rarely when you consider the volume of papers out there, but it is increasing. If you search the largest medical database of papers there is, in 1996 there were 30 papers out of hundreds of thousands that were retracted, but 10 years later it was 140. So we are seeing more of this for whatever reason, and some of it is not good reasons.
Daniel, I heard you trying to get in earlier on this as well.
Well, I think retractions generally, the effect of retractions depends on where you are in your career. If you're a young postdoc and you publish, and the following year you retract, I think you might as well go into a different profession. If you're a senior researcher with a good publication record, and you say, well, I missed something or other, I'm going to retract that paper, people will salute you and say you're a real honest fellow, good work.
It goes back to the role of the institutions, though, right? I mean, it's the role of an institution to look at something and say, hey, there's something wrong here. We need to get some answers here, right? There should be some investigational body when people begin to, because usually the researcher doesn't necessarily come to it on their own. Their colleagues around the world say, I can't find this, I'm not getting this. What did you actually do? Can you send me your reagent? I can't reproduce these results. And at that point, you want there to be some investigative body that comes in and says, okay, what's going on here? What do we actually, somebody who represents science, for the public and can say what's happened here. And as has been pointed out, that failed in the Wakefield case.
Seth, you wanted to follow?
Well, I was just going to say, I mean, it's a very good point about different types of retractions, and Wakefield still hasn't retracted his work, although the Lancet has. I might have been imprecise in my language because I think retraction usually implies that there was such a fundamental flaw in the research that it really shouldn't have been published anyway. And when you retract it, you're essentially saying, let's pull this back entirely. And I was referring, when I said people should be applauded, I was referring a little bit more to correctives, either because they get more research or better research, not because their initial research was done so poorly that those results should be completely ignored.
Okay, Daniel, let me read this excerpt to you from the Atlantic magazine from last November. David H. Friedman wrote it. And, okay, it goes like this. In recent years, large studies or growing consensuses of researchers concluded that mammograms, colonoscopies, and the PSA tests are far less useful cancer detection tools than we had been told. Or when widely prescribed antidepressants such as Prozac, Zoloft, and Paxil were revealed to be no more effective than a placebo for most cases of depression. Or when we learned that staying out of the sun entirely can actually increase cancer risks. Or when we were told that the advice to drink lots of water during intense exercise was potentially fatal. Or when last April we were informed that taking fish oil, exercising, and doing puzzles doesn't really help fend off Alzheimer's disease as long claimed. Peer-reviewed studies have come to opposite conclusions on whether using cell phones can cause brain cancer, whether sleeping more than 8 hours a night is healthful or dangerous, whether taking aspirin every day is more likely to save your life or cut it short, and whether routine angioplasty works better than pills to unclog heart arteries. Okay, there's a researcher, Daniel, named John Ioannidis, who published a paper called Why Most Published Research Findings Are False. What's he been finding?
Well, it's very difficult to pin down reality through the scientific method. Some people would say that the arts pin down reality even better, but through science you want to have it with some kind of precision that you can attach numbers to it. And scientists often are wrong, but once something is established, even if it is wrong in terms of medical practice, it changes very, very slowly. It is adopted slowly, and then even though contrary evidence shows up, does not go away. You cited many, many examples of medical practices or medical beliefs that manage to endure, even though the evidence is to the contrary. I think that is the nature of science. We can improve it, we can sharpen it up, we can have much more transparency, but it's something we have to live with. And it gets back, I think, to the integrity of the scientific organizations, to the willingness to admit error, and again, to the public being as well educated as it possibly can be through the press about what the realities are. It's never going to be perfect. I'm sure we're taking medicines today that 10 years from now, people will scratch their heads and say, why were they doing that? Absolutely useless or perhaps even harmful.
Miriam,
that's the way it works.
Right. We did a week of programs at the Perimeter Institute last year, and I remember one of the guests at that in that series of programs told us he gets nervous when he hears the expression scientific consensus. Do you agree? Is that something that we ought to be concerned about when we hear that?
Gosh, it depends the context it's being used, right? So some of the ways we figure out that a drug actually doesn't work that well is because these sort of national or international bodies get together to see, well, what's the consensus? What's the overall consensus on this? And people in practice can then turn to these consensus statements that get turned into guidelines about what really works and what doesn't. But I think that's not what this person was referring to. I think they were referring to this notion that that there's too quick a jump to what works.
Everybody jumps on, everybody's singing out of the same hymn book, and not enough skepticism out there on certain things.
Yeah, and yet that attitude, that public attitude, feeds these parents that Seth has been talking about, because it's too easy to say, well, we've got to be skeptical about what the scientists say.
Well, you've led me very nicely into our concluding chapter here. How am I doing on time, Kevin? I got about 5 minutes to go? Okay, let's see if we can do this in 5 minutes. Okay, Dr. Matthew, to you first. Scientific knowledge these days is exploding, and yet we are also seeing an explosion of a mistrust of science on issues among people who, can I say it this way, who ought to know better. Why is that happening?
I think we in science don't do as good a job as we ought to of communicating to the lay public, both in the scientific media and scientists themselves. It's ironic we go to such time and expense to train scientists so rigorously with years of PhD research, and we teach them laboratory methods. We never teach them formally, with rare exceptions, how to communicate. And they spend their careers doing, as their primary activity, exactly that. So we are failing perhaps great in our greatest way in doing that job well. And I think if we did it better, if we could just help the public and help the lay media for that matter, know a little bit better exactly what the true nature of science is, we would make some progress against this tendency to, on the one hand, be too trusting of science, and on the other, too willing to dismiss it. The reality of science that is known by people in it, but perhaps not widely known by people outside it, is it's not the same as truth. It's our best method for arriving at the truth. It has an objectivity that no other field has, and therefore we put that foremost, but it's not the truth. And where the public hears about a finding in the course of our knowledge of it depends very much on the likelihood that that knowledge is going to turn around and turn out to be a different story down the road.
Let me see if I can get the others in on this too. Seth, we know more than ever, and we're more skeptical than ever as well. Why the paradox?
Well, I think the issue of scientists and people involved in science and medicine in general not being effective communicators is a really good one. I think the issue of the people in charge of interpreting science for the public, the scientific media, doing a bad job is another really good point. And I think the way we consume information now is very, very different than it was in decades past. And so, you know, we have access. We can go on and to the Public Library of Science and get a lot of information, even though we might not necessarily know, in fact, probably don't know how to interpret it. So I think another part of the answer is just our being more intelligent consumers of information, especially when it comes to matters of our own health.
Daniel Greenberg, my hunch is, or actually, let me go to Miriam on this one because, sorry, Daniel, 1 second. What year did you win that prize for your book?
It was 2006.
2006. If memory serves, I don't think Twitter existed yet.
That's right.
Okay, so nowadays, Twitter picks up a story, maybe puts something out there about junk science, and what's that old expression about the lies around the world before the truth has a chance to put its pants on? There's no way that the truth can compete with Twitter today if it gets it wrong, is there?
Gosh, you know, I don't feel quite so pessimistic. I think, again, it matters, you know, we talked about the Lancet's different from your average small journal. I think it matters where it is. Everybody's reading everything on Twitter, but if it gets on CNN, that's different. You know, if it gets into the Globe and Mail, that's different.
Okay.
So I think there's a chance because people do rank their media differently.
Daniel, I got a minute left. You want to take it?
I would question the proposition that the public faith in science or trust of science is declining. We have some pretty objective evidence on this topic. National Science Foundation takes surveys every couple of years, and it shows that public belief in science, public support for science, public trust remains very, very high, and if anything has increased in recent years, has not declined.
You want one last word on this, Doc?
Just the impact of the internet and social media, I think, is a wild card in all of this that we don't even yet know where it's going. Zamboni is a classic example of that. Here's a paper published in a journal of vascular surgery, which wouldn't get a lot of mainstream pickup, but within a month, the MS community knew all about this paper, and the media fed it from there. So that can have perhaps detrimental consequences. It could also have positive consequences, I think, as scientists and scientific media increasingly adopt and learn to work with social media. We may have positive ways of using it the way that the general public has already had of us.
Matthew, you are one scientist and one doctor who can communicate, and we're grateful you were on our program today. Can I thank all of our guests for coming on the agenda tonight. Daniel Greenberg in Washington, the science journalist, author of Science for Sale. He's also got a novel out there, Tech Transfer, if you want to scratch that other itch. And Seth Mnookin out of New York City, the author of The Panic Virus, and as a Red Sox fan, I have to add, Feeding the Monster, which I loved. His other book about how the Red Sox won the World Series. And here in Toronto, Dr. Miriam Schuckman, research ethicist at Women's College Hospital and Sunnybrook Hospital. Dr. Matthew Stanbrook, Canadian Medical Association Journal. Thanks, everybody, very much for this.